Good evening. This is Dr. John Bennett broadcasting from Miami. Today we have the pleasure of having Dr. Ron Wheeler and one of his patients, Walter Augustine from Washington, D.C. Ron's going to talk a little bit about the procedure of HIFU, and apparently Walter had that performed on himself, and I'm sure he'll have some insights as to what it is. And so I'll let Ron take over. Okay, Ron, good evening.
Good evening. Good evening, John. Thank you. Walter, welcome. I appreciate you being here, obviously, to tell your story. And I would simply mention as an opening comment is that African Americans have twice the risk of prostate cancer as Caucasians. Prostate cancer is on the rise, and based on the fact that 250,000 men currently being diagnosed every year by biopsy, and by the year 2020, 500,000 men, according to the SEER data, the Surveillance, Epidemiology, and End Results data, predict that 500,000 men will be diagnosed. So, Walter, with you here today, a great opportunity for you to tell your story, and really I'd like you to do just that, and just tell people a little bit about what took place with you, how your education on prostate disease took place, and how you ended up seeing me, ultimately.
Okay, thanks, Dr. Wheeler. First, let me point out that I have a very strong family history of prostate cancer. When I was diagnosed, I was 53 years old. My brother, who is 1 year older than me, was diagnosed at age 39. My father was diagnosed at age 60. I have uncles on both sides of the family, my mother's side and my father's side, as well as my grandfather on my mother's side, who've all dealt with prostate cancer. So I was sort of on the watch for it. So I had been getting the annual checkup for the PSA and the DRE each year since I was 39 years old. Recently, November of 2014, my PSA rose rather rapidly, and the doctor at first suggested that it was an infection of some sort, and he put me on an antibiotic, and he asked me to come back after the antibiotics had an opportunity to work, and if the antibiotic had knocked the PSA down, he was prepared to do nothing, but if the PSA remained elevated or went any higher, he wanted to do a biopsy. So when I returned after giving the antibiotics a chance to work, the first thing that happened was I was directed straight into the biopsy room. There was no second PSA or anything. He just led me directly to the examination room. And I said, wait, I thought we were going to do another PSA to determine whether the antibiotics worked. And his response was basically, well, it doesn't matter whether it's goes down or not, because of your family history, etc. I want to do the biopsy anyway. Well, quite frankly, I wasn't prepared for a biopsy that day, and I'm glad that I wasn't, because it gave me that weekend to do some research. And as I did some research on the internet, I learned that biopsies are not only not very accurate, but they also can make the problem worse if you do have prostate cancer. So that Monday, I located Dr. Wheeler on the internet over the weekend. That Monday, I called him. And by that Thursday, I was in Sarasota, Florida, getting the MRI and a full examination.
Okay, one question I have, and I'm not a urologist, I'm a thorough doctor. When you were 39 years old, you said you had yearly exams. Did you start with a PSA when you were 39, Walter?
No, I just kept getting the PSAs and the DREs from age 39 until 53 when I was diagnosed.
Can you explain what the DRE is, or Ron?
It's the digital rectal exam.
Oh, okay, I didn't know that.
John, Walt, I would like you to talk about your experience now when you went to see physicians, and once they told you you had to do this biopsy, you ultimately decided not to do that. Was there a particular reason you didn't go for that? Just because of the injury to yourself, or how would you describe your thoughts at that time?
Well, my background is in computers, and I'm a very logical person. So when I have to make a decision, I generally try to get the pros and cons of both sides of that decision. And one of the things about the HIFU that I recall so vividly was that there was so much positive information about HIFU that it began to scare me that there was something wrong. I mean, normally a decision you would have a balance of good and bad on both sides of the scale, and you get to weigh them. But I couldn't find anything bad. I keep telling people it's almost as if you saw $100 bill laying on the sidewalk, and people are just walking by it, and you're saying, well, why aren't they picking it up? Well, maybe I shouldn't pick it up either because there must be something wrong. It almost felt like that. All the doctors who I had spoken to, my urologists, friends who had friends who were urologists, etc., and including my family members, my father, my uncle, were all saying to me, son, just do like we've done. Get your prostate removed. We all survived. Why would you want to, risk doing something different? And when I looked at the data, particularly the data for the HIFU, and knowing what my relatives have gone through after their procedures, it's so clear to me. There was nothing about the HIFU that scared me. It was just so plainly obvious that was the direction to take.
I remember seeing you on rounds after your procedure, and I'd mentioned to you that you're going to have no pain with this procedure. And that really, in my mind's eye, separates HIFU from other procedures that you would have. And I recall coming into your room, and your wife's there, your son's there, and you're sitting up in bed. And I said, so Walter, how are you doing? And this was within hours after your procedure. You looked like you had just come from a run on the beach and relaxing in bed and ready to have a little something to eat.
Yeah, I can guarantee you I had not come from a run on the beach. Although I actually felt as though I could. What I recall about the procedure, as you said, from the pain standpoint, there was none. I woke up and it was done. In fact, the very next morning, I was down at the hotel buffet having breakfast with my family, as well as another gentleman who had the procedure done the same day as myself, and we just enjoyed the buffet that very next morning. I can tell a little quick anecdote. When going back to the States, because I did the procedure in Cancun, Mexico, when going back to the States, it was recommended that we use the wheelchair instead of doing any excessive walking at the airport. I got to the counter and I asked for a wheelchair, and there was no problem. They signaled to some gentleman to bring me the wheelchair. In the next stall over from me, there was an elderly lady with a cane, and a guy comes around the corner with the wheelchair, and he goes straight to her. I mean, I'm standing there, he goes straight to her, and I go, excuse me, I think that's my wheelchair. And the elderly woman was standing with a couple of family members, and they said, Mom, did you order a wheelchair? She says, no, I didn't, but I thought they were being nice, and I thought it was mine. And in fact, I offered the wheelchair. I said, look, ma'am, if you'd like to take it, you can. And she says, oh, no, I'm fine. So here it looked like a perfectly healthy guy is taking a wheelchair from this woman with a cane.
That's a great story. Let me ask you a question. When you had your MP, multiparametric MRI scan, and I told you that you had prostate cancer, and I told you that you had an aggressive form of prostate cancer, how confident were you in what I said?
Dr. Wheeler, I don't want to say this and make it seem like I am just totally idling you. But during the time that I was diagnosed, from the time I was diagnosed until the time that I actually had the procedure done, it was exactly 30 days. And in that 30 days, you put me on a prescription, on a medication that you said would reduce my PSA. When I mentioned that to my local urologist, it was almost as if I told him that the man in the moon was coming to visit. He was completely clueless. And when I made the decision to do the procedure, as part of the preparation for the procedure, I had to have another PSA taken. And my PSA had dropped by 75% in just the few weeks between seeing Dr. Wheeler and having that PSA taken a second time. I was always convinced that that was the way I was going to go. But when my PSA dropped and my local urologist had no idea why that happened, that completely cinched the deal for me.
Wow.
Yeah, going back to basics, because I don't understand as much as both you guys probably, but I know that prostatectomy is not such a harmless procedure. There are issues of incontinence and sexual dysfunction. Is that true?
In normal. Go ahead, Dr. Wheeler.
Well,
Yeah.
whoever.
I would simply say that there are really 5 things that can take place with a radical radiation therapy or even HIFU. And those 5 things are impotency, incontinence, bowel injury, inability to get all the tissue, and urethral narrowing or urethral stricture. So Walter basically had note of all of those things that could take place, and then I proceeded to tell him, it's not so important that I tell you all these things, but more important that I tell you what my experience is with those things. And as I talked to him about that, he got that message. And by the way, the medicine that he was on is a prescription medicine. It's now generic, but it's called bicalutamide. And bicalutamide is a generic of Casodex. And what this does, this is available to all doctors to utilize. I choose to use it because I saw a person, Walter, who was in trouble. He was at risk. He was like an ice fisherman out on the ice, enjoying ice fishing, and springtime is coming. I knew with his PSA being 10.1 that he had to have that PSA reduced. So bicalutamide actually attaches to a receptor on the nucleus of the prostate cell, normal cells and cancer cells, and prevents testosterone from adhering. By doing that, the PSA is naturally going to drop. And Walter went on that medication. He saw the drop. Amazing to me that doctors at Georgetown or George Washington or anywhere in D.C. did not know that medication would do such a thing.
So generally, if Walter came to most urologists in the USA, they would have advised prostatectomy. Is that correct, Ron? Or
that is correct, because 70% of all men that are faced with prostate cancer are basically talked into having a prostatectomy. Okay. Now, I say talked into it because that's what the doctor does. That's what the doctor presents himself to be, as in a radical prostatectomy specialist. From my point of view, I tried to be totally objective. I think Walter would tell you that while I favor HIFU, I favor it because I've studied all the options, and HIFU, at least under my watch, gave Walter the best chance of success.
Now, you did an MS MRI down in Cancun?
I did an MP MRI. MP means multi-parametric MRI. So basically, it's multiple sequences that look at 3 valuable tools. Okay. T2 weighted images, which is basically an image where we're looking for dark areas in otherwise brighter areas. Secondarily, we look at the ADC map, or the we look at the SB 1000 or 1500 that really allows us to know about diffusion. In other words, how water molecules would pass through tissue. And then thirdly, we would look at dynamic contrast enhancement, or really how the tissue itself in question, what that blood supply is associated, and how well it takes up the perfusant, which is normally gadolinium.
Do you remember what the MRI or MP MRI looked like, Dr. Wheeler?
I do.
Okay, would there be anything? Okay, aside from Walter's case, would there be anything, if you looked at that MP MRI, you would say no, HIFU would not work here?
Well, first of all, HIFU would not be indicated if Walter's prostate was extremely large. Okay. So we would have to decrease the size of his prostate, and regardless of who's being treated, that's always a smart idea, because basically the routine understanding is that if you have 10 grams of tissue, and Walter had 16 is my recollection, but if you have 10 grams of tissue, for every 10 grams, it takes you 1 hour to treat that. So obviously, if we don't want a guy that has 50-gram prostate as an example, it would take us 5 hours to treat, plus the prep time, and then finishing up. So that would be a long procedure, a lot of anesthesia, and we try to avoid that.
Yes. The original question was about the local doctors. I have a couple of quick stories as well.
Okay.
After I had the MRI done, the radiologist asked if I would like to have it sent to anyone else besides Dr. Wheeler. And, of course, I had it sent to my local urologist. When he received it, he called me on my cell phone, and he says, Mr. Augustine, we received the MRI, and he says, there is an area of concern on your MRI. At that point, I had already spoken to Dr. Wheeler, and I said, well, yes, my doctor down in Sarasota is telling me that that is prostate cancer. And my urologist locally, I remember this so well, he says, no, absolutely not. You cannot determine prostate cancer with an MRI. You must do a biopsy.
Right.
Okay, that's my first doctor story. My second one is a friend of ours has a urologist, a retired urologist, who is an actual professor at some school in Texas. I don't want to say the name, but he's a retired urology professor at this medical college in Texas. And she was concerned. She told it to him, and he gave me a call, and he says, listen, you know, I've got no skin in the game. I just want to help you. I understand you're about to do this procedure. Can you give me some of the details? So I gave him all the details that I had, and then he says, and I'm quoting it as closely as possible, he says, well, I don't know anything about HIFU, but my wife looked it up, and she says it looks risky. If I were you, I would get my prostate removed, do the radiation treatment and the chemotherapy. And I looked, and I'm on the phone with him, and I said, really? You mean to tell me you would want me to do the most radical thing first? And he says, wait, whoa, 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 I'm not telling you what to do. I'm just telling you if I were in your position, that's what I would do. And then he asked, he says, so you have had this biopsy confirmed, correct? And I said, no, I've had it MRI confirmed. And he says, oh, no, you need to get the biopsy. You must get the biopsy. And then this is the part that really goes, when it goes off the rails. He says, I had a biopsy 2 years ago, and I'm okay. So because I had read Dr. Wheeler's book from cover to cover twice, I was sort of prepared. And I said to him, I said, oh, so then you realize that if you had had prostate cancer, you could have potentially spread it by having the biopsy done. And his response was, well, good luck to you, sir, and he hung up.
Okay. Is that going against the grain of standard of care, Dr. Wheeler, in America, that you cannot diagnose prostate cancer by an MRI? You need a biopsy, correct?
Well, first of all, I would tell you that the best way to answer that question is the standard of care is always floating. So it's never in one spot exactly with anyone. And we can just take the morcelator that women have used to have their uteruses ground up only to spread cancer that was present in the uterus throughout their bodies. That's a big story that's currently in all the newspapers and all the news. So the bottom line is that Walter, as everyone in my practice, knows that a biopsy is the standard of care. But I think the important point is that much like Walter would grade how he did from the procedure or how doctors would treat him, I would also grade the biopsy in some manner. So I would simply say that this is the standard of care. I agree that it is, but it is not a gold standard by any stretch. In fact, I'd suggest, based on 20 to 30% of biopsies being positive, based on a 12-core biopsy, I would tell you it's more like a 10 standard than a gold standard. But that's my opinion, and going forward, I would tell you, relevant to the MP-MRI, we've had data out of the NIH in 2011, Turk Bay et al., Pinto, Choiki, and others associated with that publication showed that the ability of the MP-MRI to diagnose prostate cancer and prove it through a biopsy was 98 to 99%. I would tell you this, people can look this up. It's NIH, it's 2011. All they need to do is look up Baris, B-A-R-I-S, last name Turkbay, T-U-R-K-B-E-Y. Beyond that, I would tell you that I have 280 patients. I had the pleasure of having an MR scanner in my office with the GE research project from 2006 through 2011. So I scanned more than 1,600 men and actually have a bevy of data. So what I did is I took the guys out of that data set that had a biopsy and had the MP-MRI, blinded from each other. So this is a classic double-blind study. I can tell you that this data was first presented at NYU in 2010 at a focal prostate cancer meeting. Subsequently, this data sits there and is ready to be brought together, collated, if you will, by some institution, maybe the University of Florida, maybe Creighton, or some other school that has an interest. This information has to get out. Our data supports that from the NIH to be identical to what that is, and here's how far we've come. London, England now tells the world that the MP-MRI is diagnostic for prostate cancer. The United Healthcare, as of January 2015, has identified the MP-MRI or a biopsy as equally diagnostic of prostate cancer. So that tells the story. One insurance company down, if you will, the rest will join on board. I believe the standard of care is dependent on what insurance companies pay. That's what directs it. That's incorrect. It should be academic. And then we talk to the insurance companies about paying for the procedure.
All right, a couple questions for Walter. How long ago was the procedure, and what is this follow-up type of instructions that Dr. Wheeler gave you?
I had the procedure on February 28th. My follow-up was a PSA at the 3-month point, which I have completed, and my PSA came back with a statistical 0. Mm-hmm. I have a second PSA at the end of this month, which will be at the 6-month point, and if my PSA remains at 0 or statistical 0, that will be the confirmation that the cancer has been eliminated. And at that point, I will go to the normal schedule of having my PSA done and the examination once a year.
Okay, Dr. Wheeler, as we've talked about, and probably Walter knows that the HIFU was up for in front of the FDA on September 1st. Now, if that passes, will that kind of alter the standard of care, you think, or will it take a while for the practice of prostate cancer to change amongst the mainstream of urologists, or do you think it'll be a long time?
Well, you know, that's a great question, and it's really somewhat of a loaded question. I would tell you this, that once it's approved by the FDA, it's now in the hands of the doctors to either use or ignore. But those doctors that want to use it need to be informed about it. I can tell you from all the doctors that I've talked to, most doctors are followers, and I'm not going to discourage them from being such, but most of them are followers and not leaders. Ultimately, HIFU will turn out to be the #1 treatment that men will have for prostate cancer. When you take a comparison of the capture data and you take a look at D'Amico's work out of Boston, just anybody could Google him, you will see that the data says that HIFU is by far the single best treatment for prostate cancer. That said, it's been available in Europe for the last 24 to 25 years. They have 40,000 men that have had the Ablatherm HIFU procedure, and obviously their data is very, very good in terms of efficacy and safety. And I will say that initially the FDA took a look at trials that were being conducted by the two companies in question, and ultimately one International HIFU, now Sonicare, and the other being EDAP, the French company from Lyon, France. Neither one of those companies really wanted to divulge exactly what the FDA wanted them to deliver. That said, they've both taken the de novo pathway to the HIFU approval by FDA. Basically, they look at the equipment, we'll call it a box. They're looking for safety and they're looking for efficacy. And I can tell you in all regards that Ablatherm HIFU is an outstanding contestant, if you will, for approval by the FDA. I'll allow Sonicare to speak in their own regard, but I have had the privilege, as you know, to understand both technologies and to treat more than 100 patients with both technologies.
Is HIFU currently being used at all for anything else other than prostate cancer in the United States right now?
It is. It is utilized for uterine fibroids. So that's a great point that you bring up. My belief is that if the technology is already available and has been probably for the last 7 or 8 years for women with uterine fibroids, we're using high-intensity focused ultrasound in those women. Why then would this be delayed or put to the back burner for so long for men or with men for prostate cancer?
Okay, so a lot of hospitals have the machine there.
No, not a lot of hospitals. Very few have it because it's only utilized for uterine fibroids. This is the Israeli company that has put that machine out, and it's quite successful. It's expensive, but I think the bottom line is that people who have success with a procedure and the procedure makes sense scientifically and it has a limited number of issues post-treatment, I would always encourage such a treatment.
How about the MSMRI, MP MRI? Are they around in hospitals now? Are they used for anything else?
I could tell you this, that the MP MRI has gained a lot of ground. Whether I had anything to do with that or not, I don't know. But I can tell you my research with General Electric back in the day, Siemens and Philips are all players in this right now. Toshiba also has a unit out. So they're very commonly seen today. Back in '06, that procedure might have cost $2,000 to have that done, performed, and read properly. Nowadays, that number is around $550.
Mm-hmm. Okay, very good. And Walter, that procedure was done this past February, you say?
The procedure was done February 28th, 2015. Yes.
Okay. Okay, so you're very happy with what happened.
I am elated.
Well, that's good. Well, go ahead.
I was going to say I witnessed, close family members being bedridden for weeks after their procedures. Right. And as I said, the next morning I woke up and enjoyed the buffet at the hotel.
Right. Well, hopefully things will change because I guess prostate cancer is the #1 cancer in the USA. Is that correct, Ron?
It's #1 in the world. It's the most dominant cancer that men get. The question that I would have for Walter, and I know we're probably coming toward a close of our session here, but Walter, what advice would you give to others now that you've experienced this, now that you've seen it? You realize now that your PSA was way too high when I saw you, but what advice would you give to your brothers? And frankly, the world are your brothers, including myself. So what advice would you give to those guys?
I'm glad you asked that question because one of the things that we have to understand as men is that unlike women, we tend to keep things to ourselves. Even though I had a father and a brother who underwent prostate cancer surgery, I didn't know what they went through until I had it myself. It wasn't until I actually had cancer myself before I actually had conversations, deep conversations with my father and my brother, whom I'm close to, by the way, about their experiences. So one bit of advice I would give to men is don't keep it bottled up. You need to talk. You need to talk to your doctor. You need to talk to other men. If you suspect something, you need to get it checked out. You need to get that exam done every year. Don't take chances. And then the second bit of advice I would give is to do your research. Do your research. It took me 1 weekend of internet searching using multiple search terms and getting back lots of information to realize who was accurate and who was full of it. Do the research, and once you see it for yourself, once you realize what's out there, I think most people will wind up doing something like this. HIFU is to me the clear victor, but let people find that out for themselves.
Well, the internet's a great source of education, and I guess you know that better than anybody, Walter. And this is let me just make one remark before we close. But I didn't realize that it was so genetic, prostate cancer. Is that usual, Dr. Wheeler? That Walter's kind of typical? It kind of is in your family tree, the prostate cancer?
Walter is very prototypical. It used to be thought years ago, and Hopkins was the leader, and they came out and they thought that there was a 10% link, if you will, to genetics. And I doubted that from the day that I heard that, because so many people I knew came in to see me. They have an elevated PSA. They ended up having prostate cancer, found the traditional way with biopsies. And long and the short is that number is now ratcheted up, and it must be somewhere in the 30 to 35% range nowadays based on genetics alone.
Very good. Well, I'd like to thank both of you guys for coming out, and good luck, Walter. I hope you stay cancer-free.
Thank you.
Thank you, Dr. Wheeler, for coming out. And I hope we have many more educational videos, because this is, I think Walter will agree, this is one area of medicine that should not be kept in the dark. People need to be educated and need to know what's out there. So, gentlemen, thank you very much.
You're welcome. Have a good day.